So again, I'm happy to meet all of you, as I'm sure I've emailed many of you. And what I'm focusing much more on treatment and try to bring up to date on what we understand about mitochondria and KAT6A. I have spent many years studying mitochondria, placed upon this here, and there's clearly something going on in mitochondria. I'll discuss what mitochondria are for those of you who are not as familiar with it, and try to link what we've seen, what parents have seen clinically with various types of mitochondrial treatment and what we understand about the biochemistry. And in doing that, I'm going to I'm not sure how to advance the slides. For some reason it wasn't working. So this is more or less what I'll be going through. And the main goal is to try to make sense of mitochondria, or let you understand what we understand about it and how we can go forward from here in taking what chemical information we have. Now, I have now collected some that belongs to about 20 patients. So we have a database, so to speak, to start off with. And I'll try to, it's a little complicated. I don't want to bore you all with biochemistry, but what I'm trying to do is give you some concept of how we approach a mitochondrial disease. So I'm at least assuming, and I was good at this, that there was some type of mitochondrial dysfunction in KAT6A. And then the question is, what can we do to make the mitochondria work better? And in part because mitochondria are so closely tied to the nutrition, that gives us avenues to work with the mitochondria and try to change their function. And suffice to say that KAT6A, one of the major effects of KAT6A or of any of the acetylation systems is to read what the mitochondria are doing. And there's a direct interaction between mitochondria and KAT6A, which is an acetylation system. Good, that shows up. So the acetylation, KAT6A is an acetylation. I'm trying to. Okay, I'll try to put it right in my mouth. Anyway, KAT6A is an acetylation, and acetate is the same thing as vinegar, acetic acid. And it's a primary fuel for the body, how food is converted into energy. Food is converted into the body, into protein and other parts of the body, and it's also converted into energy. So I'm going to go through how we try to interpret the science of mitochondrial function in a disorder like KAT6A, and therefore draw conclusions about how to treat it. And I'll be showing you examples of how this has been approached in other syndromes, some of which are very much like KAT6A in how they work. I think we talked to Esther who first contacted me about KAT6A, and I can't remember how she got in touch with me, but it was very interesting because it brought me full circle. It's been, I really am embarrassed to say that it's been 35 years since I published this first paper I published as a graduate student, and it described that histones form complexes, and those complexes are what Dr. Harris showed. These are what KAT6A is functioning, is working with. So it's really very satisfying for me to finally, after all these years, come back home, so to speak. I worked on histones and chromatin for my PhD, and then I got sidetracked into mitochondria. So now we're sort of bringing it all back together. So mitochondria are the energy sources of the cell. This is one picture, probably most of you have seen it. Each cell has many mitochondria. The mitochondria are complex organelles that are enfolded like this, and on these enfoldings is where all the ATP is made. So there are so-called electron transport chain proteins that are in this area of the cell, and this is where food is converted into energy. This just shows you what the mitochondria are like. This is staining of mitochondria to show that they're not always these sort of football-shaped organelles, but they can be elongated like this, and they travel along the within the cell, and they can actually move to where energy is needed in the cell. This is especially important in brain function in terms of getting mitochondria into the part of the brain, into the part of the cell, where action takes place at the synapse. So understanding mitochondria both as a functioning organelle and as a dispensing system, so to speak, of energy is important. We haven't addressed this aspect of increasing mitochondrial delivery to certain parts of the cell, like the brain and the synapse, but there are ways of doing that. This diagram gives most medical students nightmares, because every medical student has to learn the citric acid cycle. And I'm showing you this because there's no easy way of doing it. But we really have to understand, or what I have to do in trying to understand what's going on in mitochondria is this aspect here, the fact that, I should say, this is the citric acid cycle. And it's a true cycle that works in the cells. Food comes in here, glucose or fat or amino acids. They're converted into acetyl-CoA, and this is very important in KAT6A. Make citrate, and then citrate is broken down in several steps to come back to this compound and then make citrate again. And in this process of breaking down and oxidizing the citrate, that energy is made. What's very important is the fact that amino acids also feed in at different steps. And one of the fundamental principles that we've learned in recent years about mitochondrial treatment is that the general thinking in mitochondria is that if you have a mitochondrial problem, the mitochondria don't make enough ATP. That's actually not quite right. It turns out that the mitochondria make as much ATP as the cell needs until the cell dies. And what is in fact going on is that the mitochondria break down the cell. They cause the cell to release amino acids, and the cell then spends a good deal of time starving in effect, because the amino acids that normally would go to make protein.
Good morning, everyone. My name is Brittany Green, Communications Director of the KAT6A Foundation. Welcome to our very first KAT6A clinic. We are delighted to have you all here. We know many of you have traveled long distances to be here to support KAT6A, and for that we are very grateful. I wanted to take a moment to thank Dr. Harris for organizing this clinic and making this possible, Dr. Bjorsen for speaking to us about frontiers and therapies for epigenetic disorders, and also Dr. Kelley for traveling from Massachusetts to share the data he has been collecting and analyzing on our children. Also a big thanks to the KAT6A Foundation team for pulling all of this together and putting everything into place. We have today from the Foundation board members and committees, Jordan Moeller, Chairman, Emal Najm, President, Amy Redson, Website, Natasha Esper, Scientific and Research, and Miranda Lynn Teen Social Media. We all know how rare and extraordinary our kids are, and with the help of these amazing doctors, we are hopeful that soon we will have a lot more information about the KAT6A syndrome. We are looking forward to meeting and getting to know all of you. It is truly a dream come true to have so many of our KAT6A family together here today. Yay.
Also, Rick, we have Karen, board member. Karen Ginsburg.
Okay. Oh, I'm sorry.
Hi, everybody. Thank you so much for everybody who came from near and far to do this. We really appreciate everybody being here. We're very excited about this here at Johns Hopkins and Kennedy Krieger. KAT6A, as you all know, is a relatively newly discovered syndrome. And we know that you all have been sort of patients in search of a medical home. And so we are really hoping that this can be the start of you all meeting each other and you all meeting some of us and us taking a really good team approach to helping these very special and wonderful children as they are children and as they go on to be adults. I am Dr. Harris. I am a neurologist and neurodevelopmental specialist, and I work here at Kennedy Krieger and also in the epigenetics clinic at Johns Hopkins. So I am very interested in KAT6A. It has a lot of overlap with lots of other things that I have interested in, and am very excited that you all came to this. Here also we have Dr. Bjornson, who many of you all have talked to before. So he is here in the epigenetics clinic with us at Hopkins. Dr. Bjornson has dual appointments here in Baltimore and also in Iceland. So he is around and here and a part of our clinic, but not always present physically in Baltimore. And then we also have Dr. Jill Farner. She is also part of our epigenetics clinic. She is here at Hopkins in the clinic and also has a strong interest in KAT6A and disorders that are related to it, and is very excited to see you all. And we really appreciate Dr. Kelley coming all the way down. Dr. Kelley used to be around with us here all the time, but has moved north where it's colder. And we are glad he could come back to be with us today and share with us his work and everything that he's done with you all and for you all also. So a quick word about kind of how the day is going to go. So we have 3 relatively brief talks. I'm going to talk a little bit about just KAT6A, the disorder, what is known about the patients clinically, and what's not known, and what we what we need to continue to discover. Dr. Kelley is going to talk about his research and data he's collected in a large number of patients he's seen or collected samples from with KAT6A, and Dr. Bjornson is going to talk about some frontiers in epigenetic therapy, which KAT6A is an epigenetic disorder, and sort of where we think and hope that we are going in the future. And then after that, we're going to have a lunch, and lunch is informal, as is the rest of the afternoon. And what we really want with that time is to make sure that you all get a chance to talk to each other, because that's some of the most important things about gatherings like this, is you all learning from each other and gathering support from each other, and kids of different ages sort of getting to meet each other as well. But also we will be around so that you all have an opportunity to sort of informally talk to us and mingle with us, and we get to meet you. So hopefully that works out, and then yeah, it should be a great day. We'll wrap up around 2:30 because they're kicking us out of here at 3. And you know, hopefully, if this is all successful and you all enjoy it, we can do another one of these in the future. So with that, we'll get started with the talks. So you heard me say, and I am sure you've heard before, about KAT6A being an epigenetic disorder. So what exactly does that mean? So epigenetics is basically all of the stuff that happens to the DNA after it's already there. So the DNA code is written, it's down, it exists, but then things that happen to it after that enable it to be read or turned into proteins as it needs to be. And that's what epigenetics is. So KAT6A is a special type of epigenetic syndrome, which is a syndrome that creates a modification to histones. Histones are proteins that inside the cell, the DNA gets wrapped around. It gets wrapped around very, very tightly in the nucleus in the center of the cell, because the amount of DNA that we have in every single cell is incredibly, incredibly long. And so these proteins help it to be compact and be able to exist in every single cell. However, they are not just, you know, rocks that these get wrapped around. They are actually active proteins that have a role in opening and closing to provide this DNA the ability to perform the functions that it's there to function. And so the KAT6A protein actually has a role in modifying these histones. So what it does is it places a mark on these histones that allows the DNA to open appropriately to be read and transcribed. So thinking about this a little bit further, we can group these epigenetic modifiers into 3 main categories: writers, erasers, and readers. So writers are things that add marks to these histones, and these marks can say open up, or they can say close down. There are proteins that erase the marks, so take them away. And then there are other proteins that read the mark. So once the mark is put on or taken off, it looks and says, what is this mark telling me to do? So KAT6A is actually a KAT stands for K is a symbol for lysine, which is an amino acid. The AT is for acetyltransferase, and then the 6A just lets us know which one it is. And so what that means is that this protein actually moves an acetyl mark onto these histones and tells the histones what to do, how to be open or closed appropriately. So you can understand why, if something goes wrong with that particular protein, then a lot of things can go wrong later in the body, because your DNA is present in all of these cells, all of your cells, and if it's not there appropriately to be written or used the way it's supposed to, then you have many different problems in many different parts of the body. We know that this particular protein, KAT6A, is especially prevalent in the brain, and so that is why that is the focus of a lot of the clinical features that we see in this syndrome. So just to give you an example, you can see that KAT6A is there on top. And there are a number of other proteins that work with it on these histones. They work together in complexes. So one of the reasons that we are able to make some predictions about KAT6A, although we need a lot more information from a lot more patients, is that we know about other diseases that work in the same complex and what they look like and what their clinical features are. So you could see right below KAT6A, there are a couple of, there are 3 different proteins actually, and all 3 of those proteins are known to cause these epigenetic diseases. And that they all cause certain facial features, developmental disabilities, and things that are different and unique, but also similar to KAT6A in many ways. When Dr. Bjornson talks, you'll hear a little bit more about that, but this is some of the reasons why we think that we can possibly at some point use similar therapies to address all of these disorders, is because they work together in complex, and many of the features that we're targeting are not exactly the same, but are certainly similar. So, we've talked about what KAT6A is and what it does in the body, and you all know that the reason that you're here is that somebody has told you that your child has a problem with KAT6A. So how did this problem happen? What does that mean? So KAT6A is a genetic disorder, which means that in the gene that encodes the protein KAT6A, something happened in your child that gene wasn't correct. The code for that gene was changed and not correct. So how does that happen? Well, there are 2 different ways. So in theory, KAT6A problems are what we call autosomal dominant, which means that if one parent has this disease, has KAT6A syndrome, then there's a 50% chance that any child they have will also have this syndrome. However, we do not, at this time, know of any cases where this has been actually how this has been passed down. Most of the time, what happens is inside, when the baby is developing inside mom, something happens inside the baby only that makes a change in this KAT6A. And that's what we call de novo. De novo meaning new. It happens newly in the baby. So all of the children with KAT6A that we know of currently have this possibility to pass it down to their offspring. But as far as we know, it did not come from any parents. Yes, go ahead.
I think we just saw right on the Facebook site that there's a family in Japan with three of the 4 children in the family have the KAT6A mutation apparently. So
interesting.
Yeah, but that was pretty recent.
So that's often thought that something happened there. And what has happened there is one of the parents carries that mutation in their germ cells. So either the sperm of the dad or the eggs of the mom. So we always tell families that on average, if you've had one child with KAT6A, you have about a 1 to 2% risk. And what that means is that 1 to 2% of people have the mutation in their germ cells, but the rest of the people have no chance of passing it on. So most of everyone, 99%, 98% of people don't have that, but 1 to 2%. And that's, we often see 1 in 1 family. In your germ cells, either sperm or egg.
But not everywhere in that person's body, because otherwise they would have the syndrome. Okay?
If the parents have been tested and came back negative, so
they cannot, so even if the parents are tested, And even if the parents are tested, they can still carry a mutation in the cells that we don't have access to. You understand? So basically the risk is always that 1 to 2%, but that means that 90% of parents, if they don't carry it, are not going to have a good child with KAT6. So it's a very minuscule problem, but what we see is there are occasional families that have multiple kids. But it,
Possible to test all the cells in the body to make sure every cell is free.
To follow up question on that, so you have one child that has KAT6A and you have another child that is normal. Is there a possibility that the normal child carries?
No.
No.
No. This is a schematic of the KAT6A gene. So it's located on part of chromosome 8. There have been some cases where there's a part of chromosome 8 that gets deleted. So the whole KAT6A gene is missing. And most of the other cases that we know of occurs because of a change in the code of the actual KAT6A gene. So it can occur if a whole section of this chromosome is deleted, but it more commonly occurs because you just change one letter in the DNA that then causes that protein to be dysfunctional. So, we've talked about what KAT6A does and how a problem in this gene could happen. So, what does it look like? So, as you all know, thus far, there are only a few reported cases, which means cases that get published in the literature. You all are here, and most of you have not been published in the literature, so we know there are many, many more cases than what are published, but the way that the whole community learns about things is cases being published in the literature, and so far, there are only a few. What we do know is that we know both from the cases published in the literature and cases that we have seen in clinic, that there are similarities of KAT6A to other histone modifier epigenetic disorders. So those other disorders from that picture I showed back there, they have similarities to KAT6A. So we think we might be able to make some predictions about KAT6A from those, as well as from the actual KAT6A cases that we see. So this syndrome was first reported in 2015, so that's why I was saying it's really very, very new. Everyone who has been reported thus far are children. It is very possible and likely that there are adults out there with this syndrome, but we just have not diagnosed them. Yes?
On our Facebook group, there are people who are in their 20s and 30s.
Yes. So we are sure that there are adults, probably even older than that too, with this syndrome. But adults don't go and get genetic testing as frequently as children do. So it's very, very often in these genetic disorders that children get reported first, and then adults get found and reported later. And again, just like we said before, obviously there's a family, and that's why these Facebook groups, if you guys know each other, is so great, because that's a way to get more access to more patients. Because again, thus far, everybody reported has been de novo mutations, so new in the child, but clearly there are cases of germ cell mutations and other things being passed down to multiple children in the same family. There are some features of KAT6A that in the patients who have been reported are nearly universal. So we're pretty confident in saying, yes, these are the features, the cardinal core features of this disorder that we know of so far. Then there are some features that seem to be related. So present in only a few of the patients that have been reported with KAT6A but certainly present more than you would see in all the general population without the KAT6A mutation. And so those we kind of say, we need more information and more patients to say how closely is this related. So talking first about the features that are considered to be more universal or at least very common. So the first one is hypotonia. So hypotonia means low muscle tone. So this is sort of what people are talking about. You think of it as like a floppy baby. This seems to be, in KAT6A, it seems to be most present in infancy. So the low muscle tone is most obvious in these kids when they are newborn babies. Although a lot of times we know that it persists much longer than that. We think that most of the low tone is obvious, what we call axially, which means in the trunk, the neck, the hips, the center of the body, more than in the extremities, the arms and the legs. And in fact, the arms and the legs can at times, in some reports, be very tight as opposed to very loose. But almost universally, that center of the body, that core, is very loose. This one. The next universal feature that we are familiar with is feeding problems. So these feeding problems are probably very related to that hypotonia that we just discussed, okay? Because we know that kids get very poor oromotor coordination, which means their ability to suck, chew, swallow in a coordinated manner that allows them to eat is very, very poor. Many children, because of this, end up needing tube feedings. Whether that's a permanent tube, like a G tube, or a temporary tube, like an NG tube. Many, many kids need feeding by tube methods at some point in their life. And then reflux is very common as well. All of these things can be related to that low muscle tone, but it seems that this is prevalent enough to be an independent issue that is a feature of KAT6A. Congenital heart disease is also something that is seen very, very, very commonly, again, nearly universally in this disease. It is not necessarily or even usually some of the more severe congenital heart diseases. Usually it has to do with defects of the septum, which is the wall that separates the chambers of the heart. So you can have an atrial septal defect, a ventricular septal defect. Both of these, and even these two together, have all been reported with KAT6A. Other congenital heart disease is a patent ductus arteriosus, which just means that the blood vessel that's present for babies in utero doesn't close up the way it should in patients with KAT6A, or patent foramen ovale. There have been other congenital heart diseases reported, but not frequently. These are the most common ones that have been seen. Eye problems. So again, a lot of this also gets back to that hypotonia. So, you'll see that these things are very, very related to just general problems in the brain. So very, very commonly, these kids have one or both eyes with strabismus, which is otherwise known as a lazy eye. They can have ptosis, which ptosis means their eyelids droop down onto their eye. And then lots of other vision issues, nearsightedness, cortical visual impairment, other sort of vision issues have been reported. But certainly the strabismus and the ptosis are very common. Skull abnormalities is another one. So craniosynostosis means the skull bones in your head fuse too early. So, with all babies, they're supposed to have these soft spots. And a lot of times, our kids with KAT6A, they don't have those soft spots the way they are supposed to be. Their skull bones got completely fused before they were supposed to, which can create abnormal head shape and have to lead to surgery. Microcephaly is also commonly reported, which is a small head. A lot of the reports talk about distinctive facial features in this disorder. So things that have been talked about are what we call bitemporal narrowing, which means that this area here on the sides of your forehead are more narrow in these kids than in other kids. A very wide and bulbous nose, then several other features have been reported. Another one that's really common is this triangular or tented mouth. And again, this can come with a host of other things, but these are some of the ones that are very, very commonly seen. And as you can see in pictures, and then looking out amongst yourselves and your children too, certainly all of your children look like you in different ways. They look like their mom and dad, but they also have similarities to each other that are very different than the familial look that they inherited. And then probably the most common, most universal, biggest feature that we've seen is this global developmental delay. So when we say global developmental delay, what we mean is developmental delay in most or all areas of development. So gross motor delay is seen very commonly, meaning they're late to sit, crawl, walk, all of those things like that. This is probably twofold. It's probably partially related to brain disease and partially related to the hypotonia, or the low muscle tone. Then intellectual disability is reported universally in this disease. So most of the cases that have been reported are moderate to severe intellectual disability, although there have been a few kids who have been on the mild end. And then as part of the intellectual disability is a prominent language and speech impairment. So a large number of KAT6A kids are completely nonverbal, or if they do have words, their words are very often even behind what their intellectual disability would say their capacity is. So their language is their toughest skill, more so than a lot of their other problem-solving skills. So then we get into some of the less common or possibly associated features that are reported. So one is small burst size. So a lot of these kids are reported to be small at birth compared to what their gestational age would predict. So full-term babies being a lot smaller and looking like preemie babies. Again, this is not universal, but it's been reported in more babies than you would expect with KAT6A. Postnatal or after birth slow growth has also been reported, but this is a lot more inconsistent. Perinatal complications around the time of birth are very common. These may also be related to that hypotonia issue. But a lot of kids with KAT6A are reported to have to be born by emergent C-section. A lot of them were in breech positions. Many needed NICU admissions for some help with breathing or feeding or things like that. Again, much more commonly than you'd expect. Seizures. Seizures do not seem to be common in this disorder, but again, more prevalent than you see in the general population. But when we have seen seizures with KAT6A, they've been many, many different types. So anything from infantile spasms, which is a very severe early kind of seizures, to more common types of seizures later on in childhood. So specific behavioral features. So the answer is we have no idea. So there have been a case or two reported with who are reported to have autism. There may be an anxiety component to this. There may be other specific phenotypes, but the answer is there just hasn't been anything on it, so we don't know. We know that there's going to be the global developmental delay, and we suspect that there's going to be speech and language more so than other streams of development. But as far as behavioral phenotypes or more specific cognitive phenotypes than that. We just don't have the information yet. Sleep disturbances. So there have been a lot of sleep apnea reports. Could this be hypotonia? Yes, absolutely. And then just sleep cycle disturbances. Really, really hard time getting these kids to follow a normal sleeping pattern and sleeping through the night. How common is this going to be in this disorder? We don't know yet, but it has certainly been reported. Immune system irregularities are something we know from other epigenetic conditions that are, theoretically related to KAT6A. Some of the cases have reported frequent ear infections and upper respiratory infections in these kids. One case is reported with frank neutropenia, which is a dangerous kind of immune system irregularity, but the jury is still out on this as well as to how common this is and whether or not it's really a problematic feature of this disease. Dental abnormalities, again, common in other epigenetic conditions, have been reported. A whole host of things needs to be further delineated. Hand abnormalities. These are minor things, but lots of things reported with these kids. Curved fingers, that's what clinodactyly is. Brachydactyly is short fingers. A single palmar crease on the hand. Again, mild things, but things that we're not sure how related and how much we see in KAT6A versus other things. And then brain MRI abnormalities. Many of these kids have had a brain MRI. Many are normal, many are abnormal. All the ones that are abnormal seem to be abnormal in many different ways, and not totally clear how the abnormalities correlate to the disease, especially when we're talking about that difficult birth thing with the emergency C-section and stuff. It's unclear to say how much of these MRI abnormalities have to do with that, with a difficult birth and things that happen related to that versus how much they have to do with the underlying disorder. So more data needs to be collected on that as well. And so the bottom line is we have to learn from you all. So you all are the best source of information to tell us what is common in KAT6A and what's not, and what's a part of the core disease and what are just other things that may or may not happen. We need to draw, like I said, from other similar epigenetic syndromes and find out how much overlap and how much difference there is between KAT6A and these. We need to look at the patients already published. And again, we learn most from you all. So thank you for your time. And I can take a few questions and then we'll move on, and I can of course take questions later too. Yes?
I think another thing we were curious to find out is if there are issues around blood sugar and sort of need to persistently snack and craving of carbohydrates, because it sounds like there might be something that other families are experiencing.
So that's a wonderful question. There isn't anything out there currently about that, but certainly that's something that we see again in other these epigenetic conditions that are related to KAT6A, that they can drop their blood sugar more easily. Sometimes that can have to do with the feeding problems. There may be something more intrinsic and metabolic going on, and my guess is that Dr. Kelley is going to probably touch on that a little bit also. Yes?
So in regards to birth defects,
okay.
There's been a pretty wide range of birth defects. Some kids have some kids have none, and then there's kids like Savannah who have a lot. How does that happen? What causes differences in birth defects?
Birth defects as far as different organ systems and body parts that are abnormal at birth?
Correct.
So that can be caused by a number of things. So again, there have been a number of those reported with KAT6A, but just like you said, some here, some there, none here, and so it's unclear which parts are going to be a feature of the syndrome, but there are also parts that we know about this syndrome that can be related. So that whole hypotonia, I know I keep coming back to that, but if you're inside, in utero, if you're in mama's belly and you are hypotonic, you don't move around as much. And when you don't move around as much in there, it can actually cause some birth defects, okay? Because you're kind of stuck in one position, and that can cause deformities in the extremities and things like that. So the answer is we're really not clear what's what. But certainly, like I said, the congenital heart disease, the skull abnormalities, those kind of things are definitely going to prove to be a cardinal feature of this disorder. And everything else we got to figure out, is it random in this one kid, or is it something that we have to sort of look out for, even though it's not the most common feature of this disorder?
Thank you.
Of course, yes.
So, I'm Cora's mom. She's the youngest diagnosed as Julie today. She'll be 10 months next week, and I'm interested in the hypotonia. So what I've been told is that she has hypotonia, but I'm not sure how accurate that is because she has physical therapy and all that stuff. So she has her trunk support. She's always had really tense muscles.
Yes.
So I lay her down, she'll like hold her head up from a really young age. So she can sit up really well. That's the only like motor skill that she has. Like she doesn't roll over, she doesn't crawl or any of that stuff. And her physical therapist says that like she's compensating. Like she says that she's not using the right muscles to sit up. So I didn't know if like I've been given a wrong information in that it's actually hypertonia and she's just compensating. You know what I'm saying?
Yes.
So that's kind of my one question. And then my other thing was I didn't know about like the traumatic birth being like a thing that KAT6A kids had. Because I went into like my water broke naturally with her, but then I had a 20-hour labor and she was stuck under my pelvis, and it was like a traumatic situation eventually. Like I had to be induced eventually, and it took a really long time. So I didn't know if like I thought it was just like, oh, different baby, different things, but it might be related to her disorder.
Yes. So addressing the second question first, yes, it may be related. Okay, and again, not to keep harping on the same things, but that low muscle tone, right? So if if you're not very tight, if you have low muscle tone, it makes it a lot harder to get through the birth canal and to do everything that the baby needs to do to get through the birthing process. And so is that the only reason that we're seeing these increase in difficult births? We don't know yet. But that could certainly be related. But either way, it does seem that the KAT6A kids have more of the difficult births than the typically developing population. As far as the hypotonia versus hypertonia, it is very, very common that kids with lots of different brain diseases, and this one as well, can be low muscle tone in their trunk, in their support muscles, but very, very high muscle tone in their extremities. So their arms, their legs, their neck, things like that. And I haven't examined your daughter, but that is very, very possible. So my guess is you were not given a wrong diagnosis, that in fact there are a mix of things going on, which is very, very common, not an unusual situation. Yes.
Are you aware of any upcoming or ongoing research studies on KAT6A other than the ones that were published?
Not currently, but we're gonna talk a little bit more about possibilities for that shortly.
Okay.
One update on that. So I think many of you completed the survey that Dr. Arbolita made available to the community. So she just updated that she'll submit, I think, next week for publication.
Okay.
The results of that. So that'll be a new clinical paper, right? And it'll be 76 total patients,
Great.
52 of which will be new to literature. So hopefully that gets reviewed, approved, published within a month, 2 months, whatever the normal timeline is.
6 months.
6 months, yeah.
Yeah, so soon that'll come out. Again, that's not, I don't think that'll be so much research focused as just adding patients to literature to better characterize the disorder.
Which is very important at this stage of the new disease, so that'll be great, yeah.
Jordan, is she living in it?
No.
She's not? How do we know? I started that survey, but I don't think I finished it, and I'm curious if I got kicked back out.
Yeah, I would agree, because I did it, but I don't actually know if they made it, there was no confirmation that I finished it in the right way, so that's why I hope.
Yeah.
Could you give us a list of who's completed it? Do we have access to that?
I don't know. We can certainly ask her for it if she can. We can be provided that in advance. I mean, she did indicate that, you know, at some point she had to go and publish, right? She had to draw the line somewhere for those that had completed it at that point. So I think partially completed ones are probably not included, would be my assumption. But if you felt you completed it and submitted it, I would assume you're good and you're in there. But yeah, we can try to get a list in advance, maybe of all the included cases.
Okay, I'm sorry if you discussed this, I had to step out, but Hudson's primary diagnosis for a very long time was mitochondrial disease. He has a mito doctor down in Houston, and we did a muscle biopsy. And then, you know, we reran some blood samples into exome sequencing, and that's when the KAT6 popped up about a year ago. So he's actually on a clinical trial drug for mito. It's EPI-743. What are the benefits that you see to treating mito in these patients?
I'm going to defer that to Dr. Kelley, actually, because that's probably what he's going to talk about.
Okay.
Yes.
Is there any information on how well these kids do who have had some of the cardiac surgeries? Do they react different to anesthesia? Are there any red flags?
That's a good question. We don't know about the anesthesia. Certainly that's something that we're concerned about in any kid with low muscle tone and brain disease. So we don't know yet. Luckily, a lot of the KAT6A reported congenital heart disease are mild and sometimes close on their own without requiring surgery. But I think we do need to collect data on that because the anesthesia concerns are a real risk. Yeah.
I have a detailed anesthesia protocol for mitochondrial disease, but it applies really to any device, and I can make that available to anyone. It's good to give that to the anesthesiologist and the surgeon before.
When Hudson had open heart surgery down at Memorial Hermann in Houston, they developed a protocol just for him. They did something very different.
This actually is a standard protocol used here at Johns Hopkins.
Okay.
So it's somewhere in the process of being published by the anesthesia group, but I can make it available to anyone. Just email me.
Yes. I don't want to monopolize. So Cora has a PDA that they found, early on. They're like, oh, we'll check it later. Yeah, it hadn't closed. They're like, oh, we'll check it later. It hadn't closed. Now they're like, we'll see her again when she's free. So there have been people who had that it's closed down. If it's still there with you,
yes. Ours did at 1.
You what?
Ours did at 12 months.
Yeah. Okay.
All right.
Can I ask one?
Oh, yes.
Hypotonia, is that sort of a direct, the constipation is sort of a direct result of hypotonia?
So, yes, yes and no. So definitely hypotonic kids have constipation, right? You also have a large amount of nerves in your gut, just like you do in other parts of your body. And so it's also common that kids with brain diseases in general have constipation. So, I think that it is very, very common. It's something that we hear frequently. There are some disorders where we hear it more than others, even others with hypotonia and brain disease. So I think it remains to be seen, where KAT6A falls on that spectrum. If there are really specific constipation GI problems that go above and beyond, hypotonic kids with intellectual disability, or whether it could be that. But the answer is yes, hypotonia and intellectual disability both have a correlation with constipation.
Is it possible that antibiotics can affect kids differently? The reason I asked, for constipation, Sarah dealt with constipation for a long time, and then last year
about this time, she had an ear infection after her initial tooth fell out, which didn't clear. They gave her 3 rounds of antibiotics, increasing their strength.
Yes.
Through the end of April, and then the beginning of May, her bowels went completely the opposite way. And starting in July, they had us doing elimination diets. I mean, she was dairy-free, soy-free, everything free that you could think of. She was free. She was free of. And we reintroduced these things, and it seems like now she has an issue with eggs. Gluten seems fine. We haven't reintroduced dairy yet. Soy protein seems to be an issue, but not less of it. But these things weren't a problem. I mean, she's 5.5. These things weren't issues at all until May. Is it possible that the runs of antibiotics could have
certainly we know that loss
permanently, or
certainly we know that loss of antibiotics can change your gut flora, which can then lead to lots of different GI problems. And how permanent that proves to be sort of depends.
Yeah, because we're trying to figure out if it's an allergy, if it's a true allergy, or if it's like
something
how to deal with it.
Absolutely. Absolutely. Dr. Kelley, do you want to say something about constipation?
There is a specific But there is an intrinsic reason
So I think we're gonna move on because we'll be here and we'll be able to answer more questions, and we want to get through everything and make sure that you all get fed. So Dr. Kelley, do you want to go next? Whatever you prefer. We can definitely hook the laptop up.
I just don't know how to set it up here. Do you know how to set it up?
I will do my best.
If not, I'll just let you
That's really sweet. Is it good?
They try to get out.
Singapore made fun of myself. Do you want to say that?
Yeah, I think
Somebody was showing me he was like that.
The next lecture, Dr. Kelley's going to start. Go ahead.
So I have a quick with Kelley. I'm sure I've spoken or emailed to many of you. Yeah, this is a problem. Hello?
Yeah.
It's like the price is right.
That's better. I'm too otherwise. So again, I'm happy to meet all of you, and I'm sure I've emailed many of you. And what I'm focusing much more on treatment and try to bring up to date on what we understand about mitochondria and KAT6A. I have spent many years studying mitochondria, place upon I was here, and there's clearly something going on in mitochondria. And I'll discuss what mitochondria are for those of you who are not as familiar with it, and try to link what we've seen, what parents have seen clinically with various types of mitochondrial treatment and what we understand about the biochemistry. And in doing that, I'm going to I'm not sure how to advance the slides. For some reason it wasn't working. So this is more or less what I'll be going through. And I'm just going to, the main goal is to try to make sense of mitochondria, or let you understand what we understand about it and how we can go forward from here in taking what chemical information we have. Now, I have now collected some metabolic studies on about 20 patients. So we have a database, so to speak, to start off with. And I'll try to, it's a little complicated, I don't want to bore you all with biochemistry, but what I'm trying to do is give you some concept of how we approach a mitochondrial disease. So I'm at least assuming, and there's good evidence that there was some type of mitochondrial dysfunction in KAT6A. And then the question is, what can we do to make the mitochondria better? And in part because mitochondria are so closely tied to nutrition, that gives us avenues to work with the mitochondria and try to change their function. And suffice to say that KAT6A, one of the major effects of KAT6A or of any of the acetylation systems is to read what the mitochondria are doing. And there's a direct interaction between mitochondria and KAT6A, which is an acetylation system. Good, that shows up. So the acetylation, KAT6A is an acetylation. I'm trying to. Okay, I'll try to put it right in my mouth. Anyway, KAT6A is an acetylation, and acetate is the same thing as vinegar, acetic acid, and it's a primary fuel for the body, how food is converted into energy. Food is converted into the body, into protein and other parts of the body, and it's also converted into energy. So I'm going to go through how we try to interpret the signs of mitochondrial function in a disorder like KAT6A, and therefore draw conclusions about how to treat it. And I'll be showing you examples of how this has been approached in other syndromes, some of which are very much like KAT6A in how they work. I think it was Dr. Esther that first contacted me about KAT6A, and I can't remember how she got in touch with me, but it was very interesting because it brought me full circle. It's been, I really am embarrassed to say that it's been 35 years since I published, this first paper I published as a graduate student, and it described that histones form complexes. And those complexes are what Dr. Harris showed. These are what KAT6A is functioning, is working with. So it's really very satisfying for me to finally, after all these years, come back home, so to speak. I worked on histones and chromatin for my PhD, and then I got sidetracked into mitochondria. So now we're sort of bringing it all back together. So mitochondria are the energy sources of the cell. This is one picture, probably most of you have seen it. Each cell has many mitochondria. The mitochondria are complex organelles that are infolded like this, and on these infoldings is where all the ATP is made. So there are so-called electron transport chain proteins that are in this area of the cell, and this is where food is converted. This just shows you what the mitochondria are like. This is staining of mitochondria to show that they're not always these sort of football-shaped organelles, but they can be elongated like this, and they travel along the within the cell, and they can actually move to where energy is needed in the cell. This is especially important in brain function in terms of getting mitochondria into the part of the brain, into the part of the cell, where action takes place at the synapse. So understanding mitochondria both as a functioning organelle and as a dispensing system, so to speak, of energy is important. We haven't addressed this aspect of increasing mitochondrial delivery to certain parts of the cell, like the brain and the synapse, but there are ways of doing that. Now this is this diagram gives most medical students nightmares, because every medical student has to learn the citric cycle. And I'm showing you this because there's no easy way of doing it. But we really have to understand, or what I have to do in trying to understand what's going on in mitochondria is this aspect here, the fact that, I should say, this is the citric acid cycle, and it's a true cycle that works in the cells. Food comes in here, glucose or fat or amino acids, they're converted into acetyl-CoA, and this is very important in KAT6A. Makes citrate, and then citrate is broken down in several steps to come back to this compound and then make citrate again. And in this process of breaking down and oxidizing citrate, that energy is made. What's very important is the fact that amino acids also feed in at different steps. And one of the fundamental principles that we've learned in recent years about mitochondrial treatment is that the general thinking in mitochondria is that if you have a mitochondrial problem, the mitochondria don't make enough ATP. That's actually not quite right. It turns out that the mitochondria make as much ATP as the cell needs until the cell dies. And what is in fact going on is that the mitochondria break down the cell. They cause the cell to release amino acids, and the cell then spends a good deal of time starving in effect, because the amino acids that normally would go to make protein are being broken down. And eventually the cell runs out of one of these and the cell dies. So it's not ATP, it is ATP synthesis, yes, but to understand mitochondrial disease is to understand what the mitochondria are doing to the cell to make energy. And if we can, if the mitochondria are impaired, we can work with the mitochondria, we can treat the mitochondria in a way that they can make that they won't damage the cell, then things will be better. So the citric acid cycle, as I said, is located on these cristae And this is a diagram some of you have seen. I did a webinar a while ago, and this is a diagram I made showing what might be going on in the mitochondria. I showed you acetyl-CoA before, and acetyl-CoA is converted into acetyl-carnitine, and then acetyl-carnitine is converted back into acetyl-CoA and acetate. And it's acetate that gets into the nucleus. And that's converted into acetyl-CoA. So the goal is to increase acetate in the cell, in the nucleus. And KAT6A, as you know, patients who have a deficiency, they have one normal function. And therefore, if one can increase the amount of acetyl-CoA that the KAT6A will use, then it can partially compensate for the deficiency of the KAT6A protein. And that's the primary goal of treatment. That's only one aspect. That's treating the primary defect. But it's not likely to be a complete cure of the biochemical abnormality, and that's why we have to look at the rest of biochemistry, understand how to support the cell as much as possible. And I should say what I believe carnitine is doing is enhancing the transfer of acetyl-CoA out of the mitochondria where it's made and into the cytoplasm. And that's converted into acetate and taken up into the nucleus. So this is where carnitine may be playing a role in the improvements that people have seen in their children who are taking carnitine. And what we know for sure right now is that carnitine is beneficial. And even though we don't have formal trials, I think the anecdotal experience has been quite striking in my experience as a mitochondrial specialist. And it also, the kind of changes that I've heard about are exactly what we see in treating certain groups of mitochondrial diseases, where primary abnormality in the transport chain. So the question is, what is an amino acid? An amino acid is a compound that is in protein. Protein is a string of amino acids, and when someone eats, the protein is broken down into the individual 20 amino acids that are in protein, taken up into the bloodstream, distributed to the body as needed. A lot of it goes into muscle, a lot of it goes into liver as a store, but some of it goes directly to the brain and other places. And what I'm trying to show here is that there, some of you are aware that I asked that the amino acids be obtained at 4 to 5 hours fasting. And that's a special point of equilibrium where the blood levels tell us much more about what's going on in the mitochondria than if you do the blood right after the meal or after overnight fasting. And what I'm trying to show here is that these values are, I'm going to skip that and go on explain better. So again, all of these amino acids will feed into the mitochondria. When the surge of protein from a meal is gone, then it's the mitochondria that determine the levels of amino acids in the blood. So if you obtain the blood at 4 to 5 hours fasting, that you can interpret those levels as a sign of what's going on in the mitochondria. And what I was showing back here is that in complex 1 deficiency, this is a child with autism. In complex 1 deficiency, there is an increase in glycine and alanine, and it's about 2-fold increased here. And this might not be apparent if we're eating right after meal or after overnight fasting, but we can look at this profile. This profile by itself is essentially diagnostic of complex 1 deficiency or the equivalent thereof. So one can look at these ratios and draw very specific conclusions about mitochondrial function. show you that I've already said it. I've done a lot of studies on autism, and it turns out that about half of autism is caused by mitochondrial abnormalities. And there are two types of autism: regressive, where children are normal, they lose their skills, and non-regressive, where children are typically not normal from birth. And as I said, I'm looking, this is a method where this is what I have done for all of your blood samples, is if we obtain the blood and do a calculation on it, we can put a normal blood level into 1.0. So what this shows is in the children with autism, with regressive autism, that glycine and alanine are increased relative to the control. This is the control range here, the normal range. And that these are distinctly increased. And this allows one to, if the child has symptoms of autism, to just do an amino acid study rather than a muscle biopsy and determine if there's an abnormality in mitochondrial function. And this also, the combined increase in glycine and alanine also tells you how to treat the child. So this is the kind of information that we're looking for in KAT6A. Also say, I'll come back to this later, that in KAT6, in some of the patients with autism, the tyrosine is low, and that is relevant. Tyrosine is a precursor of neurotransmitters, dopamine, norepinephrine, epinephrine. And if one is deficient in tyrosine, then neurotransmitters tend to be low. And I'll show you the consequence of that later. This is a standard treatment for complex 1 deficiency that we do for mitochondrial autism. This is the kind of cocktail that Chloe started on, and it is designed to do two things. One is to augment the activity of complex 1, and the other one is to treat reactive oxygen species or free radicals. These form in conditions where, in certain types of mitochondrial problems, and they damage the mitochondria. And if the mitochondria are damaged by free radicals, then they don't work as well, and they make more free radicals. And that's why mitochondrial conditions often get worse with age. And if we can protect the mitochondria, first we can stimulate the mitochondria to make more energy, and we can protect the mitochondria with these. And with this specific combination of antioxidants. And this works very well in most classical mitochondrial problems. And right now, all I'm convinced of is that carnosine in particular is beneficial. But we now have evidence that maybe the older children with KAT6A will eventually develop mitochondrial dysfunction. And therefore, the question we have is whether treating with carnosine and cationic acid would prevent this damage to mitochondria over time. It's very specific. We can do tests that tell us very directly whether the mitochondria are damaged and if they need antioxidants. And in general, I have not seen that in the tests that have been done, except in a few older patients. So they have suspicion that it is getting worse with time, and that because there's such a clear benefit from carnosine and cationic acid, which work together, then there's a very real possibility that that alone will be adequate. There's no harm in giving the antioxidants, just a harm to your pocketbook, but it's you don't have to give all those extra medicines. And that's one of the goals that I have in the next few years, is to set up some formal studies with children to be able to study this aspect and to determine whether through formal treatment protocols where we monitor more frequently and do various extra studies to really answer the question of whether or not carnosine by itself is adequate. I'm not saying you shouldn't give antioxidants, and I have discussed things with Chloe's father on the phone a while ago, and it's quite clear that the immediate effect, the relatively rapid effect that one sees with the cocktail. So Chloe was given the cocktail, and it was, I think, more or less based on my recipe, and some benefits were seen within a few weeks. And the antioxidants take a minimum of 3 months to have that effect. So if we start the cocktail all at once, and the child gets better, we notice the quantity at least that is working. And what we don't know is whether the antioxidants have an added benefit. And that's what we'll try to sort out. It's going to take more normal overlap studies, but that's the primary goal that I have as someone who works with my family. So skip that. So here is, so I'm talking about amino acids. I'm going to give you now several instances where finding an where the amino acid is critical to the treatment of a mitochondrial problem. And this is about methionine. And methionine is important because there has been some methionine deficiency in patients with KAT6A. And suffice to say that in certain types of mitochondrial problems, methionine is the critical deficiency. As the mitochondria become weaker and they draw more on the amino acids, some amino acid has to run out first. And it's usually methionine that runs out first. And methionine is not a lot of fat in the diet, and there's not a lot in the body, and it's a very, very important compound in many things other than making protein. So this is a child with Leigh syndrome, which is a very severe type of mitochondrial problem, and it's fortunately treatable now, and I've followed this patient for now 20 years. And when he was in his late teens, he started, all I can say is that he just wasn't as well as he should be. He's been well for many, many years, and he just started having more problems. And I kept racking my brain, he's on a treatment that I know is working, and what could be going on. And just in reviewing his blood counts, what I found was that his red cells were getting larger. And a larger red cell is a sign of B12 deficiency or folate deficiency. So I measured his folate and B12, and they were high, not low. And yet he clearly had a rising MCV, and it really jumped up here, as you can see. This is the upper limit of normal, and it jumped above normal. And when I couldn't find that he had B12 or folate deficiency, I measured another compound, which many of the children have measured, called homocysteine. And if normally when there's a blood problem where the MCV, because of the size of the red cell, is going up, the homocysteine is high, but in this child, the homocysteine was low. The main source of homocysteine is methionine. So I put him on a relatively small amount of methionine. And I should say here, I forgot to mention, the methionine level in blood was not low. So here's 7 to 43 is the normal range, and it was 13, 22, and 20. But when I calculated it as relative to all the other amino acids in the blood, it was low. Not very low, but it was low. So this would never be picked up by a regular laboratory. One has to do a ratio study. And so I put him on a small amount of methionine, and his MCV has dropped like a stone. It dropped as fast as it possibly could, given the fact that red cells live for 4 months. So this is proof, and he got better clinically. That's the most important part. So that's proof that the methionine deficiency was what was making him sick, not the fact that he had a mitochondrial problem caused the deficiency of the methionine. That led to this is a young man who I have been treating for the past few years, and he has mitochondrial autism. So he was normal to a year's age, had an illness, lost skills. He actually had 2 episodes of losing skills, and he's sort of on the borderline between Asperger's and autism. And he has to be, he's not an independent child. And what I saw in his studies is that he had the usual things that we see, a high level of proline, glycine, and alanine in particular. And he also had a low level of tyrosine. Again, the tyrosine level itself was not low. At the ratio, it was 0.7, anything below 0.8 was low. So it was very subtle, but it was real. And so it decided to do that, to put him on a supplement of tyrosine. And this are some photographs of him before treatment, and it shows that he's not a very happy camper. And his mother says that he's just always, he's okay, he can take care of himself reasonably well, but he just never enjoys anything. And he really had mitochondrial dysfunction, and he also decided to put him on tyrosine. And that's the difference before and after. So this happened in December 2016. His mother's, he's just totally changed. He's outgoing, verbal, and his mother said that just this Christmas 2016 was the first time he enjoyed Christmas. And he's continued to do extremely well. And so again, the subtle deficiencies of amino acids are very important. And what the reason it's hard, the reason it's not been recognized before, and the reason it's hard to detect is that if there is a deficiency of amino acid in the body, the liver tries to prop up the level in the blood to supply more to the rest of the body. So the blood can be low normal, but when you take it can be very low. So that's the reason that this again, not been found before, and we're finding, we found it first in a syndrome called Bart's syndrome, arginine was low, and that cured the heart disease in Bart's syndrome. So now we're finding that the three primary victims, so to speak, in amino acid and mitochondrial dysfunction. One is arginine, and this it just to say that tyrosine is a precursor for neurotransmitters, and in effect what was going on is that he was deficient in the nerve cells in tyrosine. In fact, when I put him on tyrosine and he got so much better, his tyrosine level didn't change. It stayed the same. All that extra tyrosine was going into the nerve cells, and it was really a tiny amount compared to it was only about 25 to 30% of daily average intake of tyrosine, but he was deficient and he needed it. Here's another young man I followed for many, many years. And all we knew is that he had a syndrome, and he had some signs of mitochondrial dysfunction. I had tried treating him with a mitochondrial cocktail, and it helped a little bit, but it really didn't help a great deal. And he was really a young child, not doing very well as he got older. Found that he also had a deficiency of iron, as shown here. Again, the same kind of range with normal levels in the blood. And what we found out when we found that he had he had a abnormality. what we found out is similar to KAT6A. It's a histone modification, but it's methylation, and the methyl comes from methionine. And he has the same kind of abnormality. He has one copy that's normal and one copy that is abnormal. And so I put him on methionine, again, a very small amount, and that was the change in him. That's over a matter of just about 6 months, I think. Clearly he has trouble still. He's not an independent person, but he started telling his parents what he wanted, and he hadn't done that. And he was very different. He put on a fair amount of weight. He started eating it. Had to put him on a diet, to be sure. But just to show again, methionine deficiency is critical for him. And methionine, I'll show, comes in here. And the most common site of block in mitochondrial problems is in the first half of the citric acid cycle. So if there's a block here, and we can show this block by measuring these compounds in the blood. Again, methionine and these 4 amino acids here become more important, and the mitochondria uses those to make energy. And methionine, even though all 4 can provide energy in this way, methionine gets picked on for reasons we don't understand. And that's the weakest link first. So in general, just to give you some idea of our resources for treating mitochondrial problems, and we've only really addressed the issue of carnitine and KAT6A. I have to first understand more about the metabolism in KAT6A to know how to approach it. But these are the kind of things that we do. Again, carnitine and hepatinic, you know about. Complex 1 is, in almost any kind of mitochondrial problem, complex 1 is lower, has lower activity, and it happens to be the way carnitine and hepatinic work. It literally turns on a switch that activates some part of complex 1 that's not active. And that's why you see such a rapid effect. Carnitine is water soluble, it builds up in the body very quickly, and hepatinic acid works in concert with carnitine to activate complex 1. So then we use antioxidants, as I already mentioned. Another way that has not been explored in KAT6A, which is very important in some of the mitochondrial diseases I treat, is stimulation of the NRF2 pathway. I think someone here mentioned KAT6A. Is that?
Should not, yeah.
Did you mention KAT6A?
Yes, Hudson has been on that for probably 4 years now.
Okay. And what did you see?
So he was admitted to that under the emergency treatment protocol, and we immediately saw an immune system reaction. Like, he used to be so sick constantly, multiple hospital admissions, and now, I mean, maybe one hospital admission a year. So definitely helped his immune system greatly. And we saw Dr. Inns at Stanford, and the very first thing he said when we came back after having been on it for 6 months was his attention span is so much better. He can focus on things now, to where before he was very chaotic and disorganized.
Okay. So these are, again, that's something that needs to be explored. The question is if you gave both carnitine, pantothenic acid, and epi743, would that have an additive effect? What epi743 is, it sort of has an interesting history. They had found that gamma-tocotrienol stimulated what's called the NRF2 pathway, but you can't patent a natural compound. So the company that is making it engineered it so it had the same function, but they like stuck a method group on trienol, so it's called a drug. But I've been using gamma-tocotrienol for about 20 years, in my patients, and it definitely can help. It doesn't help all mitochondrial problems. I just don't know the question right now of whether adding that in addition to quantity. Is he on quantity now or just the epi?
He's just on the epi. They made us get off of CoQ10 to get onto the trial. He could be on carnitine, but we.
So
he was on that for a long time.
All this data is very important. I'm not saying he should be on carnitine, but that's the kind of question. What I usually do clinically is I'll start a patient who has a mitochondrial problem on carnitine and the antioxidants. Sometimes if they're very sick, I'll throw in the gamma-tryptophan at the same time, and sometimes I'll add it later. This, I should say, is available over the counter or by email.
So I'm just wondering, my daughter has been told by several specialists that her levels are fine enough to not need any of this. However, that was once told to us by a GI doctor, and it was again told to us by a geneticist. So I'm just wondering, at what point does somebody make the final decision to say whether or not someone would truly benefit from the mitochondrial treatment?
It has to be evaluated, but most patients, just to give you an example, almost all patients in whom I make a diagnosis of mitochondrial autism, all the laboratory studies are normal. Because the values are not that increased, one has to use the ratio method to show that there is an abnormality. And then we can go on and confirm the abnormality by other means. But as a screening test, amino acids are very valuable, but the commercial laboratories, if it's within their normal range, which can be very broad, they just say it's normal. They don't recognize it. So it has to be evaluated by someone who knows mitochondrial function, not the GI doctor could, but in general they don't. So if that is who is looking at the data to make sense of it, and simply saying that everything is in normal range, unfortunately, for diagnosing mitochondrial dysfunction, it just doesn't work. You have to have someone who knows mitochondria to interpret them.
I have a question about the B5. What does it do to just make the carnitine more effective? What is the role of B5? I know that it was on the other slide listed. Is it necessary to give that as well? Or?
I can show you how to go back to the beginning.
Sorry. I had a really hard time administering that to him.
Yeah, it is a, here it is. So, acetyl-CoA, when we work with, it's very common that when the mitochondria are being overworked, that they use up B vitamins more rapidly. In Barr syndrome, which I mentioned before, B6 is very often deficient. But it's enough to cause trouble, but it's not enough to be recognized as B6 deficiency per se. In fact, B6 deficiency usually leads to an increase in binding. Pancreatic acid is the source, is making acetyl-CoA here, or this is it. CoA is made from pancreatic acid, and therefore, to make sure that there is adequate pancreatic acid, we give our adequate coenzyme A, we give pancreatic acid. It also, studies have been shown, that unlike some vitamins, one can increase the level of acetyl-CoA, of CoA, simply by giving B5, giving pancreatic acid. Unfortunately, it's very hard to sort out what's helping, or if we give a cocktail to a patient, it's very hard sometimes to sort out what is doing what. And I'm reasonably convinced that in patients with classical mitochondrial disease, pancreatic acid can help. I don't know for sure for KAT6A, and if you're having trouble giving it, what I would do is give less of it The daily requirement is 15 milligrams, and most of the patients are getting something like 50, and it can be irritating to the stomach. So if you simply give a multivitamin, which has 15 milligrams of pantothenic acid, that is enough to cover a deficiency, a secondary deficiency. It's not going to give the amount that we give mitochondrial patients, but I can tell you right now that it definitely is needed. So I would not be terribly concerned as long as you're giving at least one daily requirement extra. That would probably be enough. I just wanted to show you what I'm working with now in terms of So I'm going to show you a summary of the amino acid data that we have so far.
Just a minute. Just a minute. No, here.
So this is the summary of the data that we have so far for KAT6A. It's about 20 patients. How many exactly. And it's not consistent. You don't always see abnormalities, but they're not the same in every child. And this may be because, as I explained, the whole interaction between KAT6A and mitochondria is related to diet. And therefore, the diet a child is on could influence, will influence the function of mitochondria, or the interaction of KAT6A with mitochondria. And that's very important. Diet is the main treatment for mitochondrial disease. And this is one of the things that we have to understand. What is the best diet for someone with KAT6A? So to show the most unusual findings are a high level of citrulline, which is here. And it's about half of the patients. Again, this is two standards. This is Z-score. So anything above about 1.25 is normal. So half of the patients at least have a high citrulline level. They also, a good number have a high asparagine level as well, which is here, and some are quite high. They have high alanine levels, some of them. This is more characteristic of typical complex 1 deficiency type of mitochondrial dysfunction. They also have, I can't really explain it, they have a relatively low level, as a group, have a low level of glycine. So there are many, all I can say is that there are many effects of KAT6A deficiency on mitochondrial function as manifested in the amino acids. We know that carnitine is helping. It may be helping not because it's changing any of the amino acids, but because it's stimulating production of acetyl-CoA, which then gets into the nucleus, which is where it is needed. These are all the things that we have to tease out. I've been working with this other condition, Barth syndrome, for more than 20 years. And fortunately, every few years we come up with something new. There are 3 main problems in Barth syndrome. One is a muscle problem and a heart problem. One is neutropenia, a low white blood cell count. And the other one is growth delay. And gradually, bit by bit, by studying the metabolism, studying the fatty acids, the amino acids, we've been able to figure out the cause of all 3 of those problems. And we've treated one, and we're pretty sure how to treat the other. But just to tell you, it takes a long time and to gather a lot of data. Unfortunately, we now have a sufficient number of children to study that we can gather that kind of data. And it's a complex process to an easy answer. I should also say, each child is probably, as these show, each child is going to be somewhat different. So there's no one treatment fits all for KAT6A. And that's been true for Barth syndrome and other mitochondrial problems. Even though the diagnosis can be the same genetically, the treatment is going to be affected by other genes that a child has. But we have these tools, these metabolic tools, looking at the link between nutrition and metabolism. And because KAT6A is a metabolic protein, it has metabolic interactions with acetone, which comes from mitochondria. That is what we need to do. I'll address one question right now and then open up to. There's a severe. There are two problems with the GI tract in KAT6A. One is there's a high incidence of malformations, and this is evident. Or a structural abnormality, because there are now 4 patients who have had intussusception, which is not a very common finding. And it's usually associated with dysmotility of a caused by structural abnormalities in the gut. It could be other causes, but this has to be main thing. The other thing is that chronic constipation is a real problem in many mitochondrial problems. And what we have found in measuring citric acid cycle intermediates is that the level of citrate often is low. Now, unfortunately, I have not been able to measure that in KAT6A, but to go through a sequence, if citrate is low, the citrate is made by mitochondria. Mitochondria are working well, they make a lot of citrate. The same citrate that's in the citrus juice. That citrate is the only source of acetyl-CoA in certain types of cells. And that if acetyl-CoA and the primary neurotransmitter of the gut is acetylcholine. And therefore, if acetyl-CoA, and that's made from acetyl-CoA plus choline, if acetyl-CoA is low, then the gut doesn't work as well. And what we found in treating a number of children with mitochondrial problems, that simply giving citrate will increase the production, we presume, it's increasing the production of acetylcholine for the gut, and the gut starts working. The first time I used this, the child was on a drug that's not available anymore, Propulsive, because she had such severe constipation, she went once every several days. I put her on what I guessed would be, this first trial treatment, what I would guess would be the right amount of citrate. And I got a stat call from the floor saying that she's diarrhea. So we just backed off on the dose, and ever since then she's been fine. And I've done this in a number of patients. So-called, you may have read about pseudo-obstruction. In a typical mitochondrial disease, the primary cause of pseudo-obstruction is the deficiency of citrate. And we were able to show this by measuring the citrate in patients in their blood. And when it's low, they typically have constipation, and it gives citrate, and the gut starts moving. But I want to say it's not going to be the cause of all constipation, but it's happened enough children with KAT6A have been put on citrate to believe that this is an option and needs to be explored. They're very specific. I've worked out now exactly what dosage one should start on and how much to increase to see when it's going to work. So, and of course it's not published yet, but it can be very effective. And it's much better than giving all these medications. It's quite natural. One interesting story, there's a boy who had autism, complex deficiency, and very severe constipation. And before I started treating him, his father told me that they had to lock the refrigerator because he would go in the refrigerator, find a bottle of real lemon juice, and drink it down. And that's very high citrate. It's as high a citrate as a medication form. So he was treating himself. He really felt better when he drank that. And so just to show you that it's a very important aspect of certain mitochondrial problems. So that's the end of my
No, it's fine. I just was trying to understand, are you saying that sometimes there's an actual physical issue with the intestines, and sometimes it has to do with low citrate levels, and you're seeing both with KAT6A?
There's evidence of there are structural elements, so that could be, for example, there could be in some other genetic conditions, the absence of nerves, there's a gap in the gut that has no nerve, or intussusception is often caused because there's constriction or hematoma or lump extra tissue on the inside of the gut that serves as the starting point of this process. It's essentially what is happening. The gut is folding over on itself. And it's 4 patients now are patients that we have that. And that's a pretty high incidence to make you think there was something cats that have had intussusception. And it's just not a common thing. And it could be due to constipation by itself, but most children that have severe constipation do not